Welcome to Joint Effort with Des Moines Orthopedic Surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Well, I'm here with Jason Sullivan, who is one of our hardest working, youngest surgeons here, high volume surgeon, does a lot of sports medicine. He's also here at DCG. You're the team doctor for DCG, right?
Yeah, last 7 years.
Which is our one of the best 3A sports teams in all of Iowa.
Absolutely.
Now, I'd like to talk a little bit about your competitive streak. You know, I know that you grew up playing sports. Was it Dowling?
I did, yeah.
Played sports at Dowling, basketball. I also know that you were involved in some kind of at Notre Dame when you were there, you were involved in some kind of a 5-on-5, the biggest outdoor basketball tournament.
Yeah, absolutely. Right? The bookstore basketball tournament in Notre Dame is a pretty big deal.
Yeah.
About 500 teams. It's just fun for people that weren't good enough to play sports in college, honestly. But I rode the coattails of three guys that played on the football team and ended up in the NFL.
Really?
And I was the only guy on the team that couldn't dunk. So that was enough for my competitive streak to be on a winning team.
Were you a guard?
I was a guard.
Yeah.
They told me to shoot the ball, and they said eventually I'll make it, but they'll keep getting the rebounds for me.
And did you guys do pretty well at that?
We did great. Yeah, we had Justin Tuck on that team, who was a 10-year vet in the NFL, and he just got all the boards, and we beat everybody pretty handily.
Wow!
So
you won it. You won the whole.
We won the whole thing.
Oh my gosh!
We won the whole thing. Yeah.
That is amazing. I know you're competitive because we used to actually lift weights together and do all sorts of weird stuff at like 6 a.m. before we went to surgery.
Yeah, you ditched me. I still show up every morning thinking you'll be there.
Well, I'm a lot older than you are, so I had to quit. I knew when to call it.
Yeah, those are good times.
Those were good times.
I think the last time we did that, I almost passed out, and we were lifting your weight instead of mine, and I couldn't get through it.
Well, that was the best shape I've been in, but it's gone downhill since then. One other thing I want to talk about before we get into talking about ACL reconstruction and some of the hot topics and controversies and things about that is I did want to talk about a controversy that I heard about, which is that you forced a vegan endurance athlete to eat a zombie burger. Is that correct?
Yeah, that was 2016, New Year's Eve. And long story short, I was kind of losing touch with my eating habits and working out. And a friend of mine who's an anesthesiologist who's in very good shape.
Brad Bergman.
Yeah, yes, Brad.
He gave me permission to use his name on the podcast. He's one of the fittest guys in Iowa, probably.
And he researches all this, how to eat right, how to exercise, longevity medicine. I had a plate of Olive Garden with all the pastas on my plate, and he walked in one day at the surgery center and said, "Hey, Sullivan, you know your next meal is guaranteed, right?" And just laughed at me and walked out. And then took a picture of me and sent it to everybody. So at that moment, I said, you know what, I got to kind of get control of this thing. And he's a runner. I said, all right, pick a 5K time that I can't make. And he said, fine. We settled on 19 and a half minutes.
On a treadmill.
On a treadmill.
This is not out running in the streets, which is much different.
We negotiated treadmill because I think it's a little easier, and it was wintertime. So I trained for about 3 months for this, and I was pretty out of shape at the time. If I win, he's got to eat a zombie burger, and he had not had meat in about 10 years. And he had to have anything else we ordered, a shake, fries, whatever.
If you're not from Des Moines, zombie burger is not like just a piece of meat. There's all sorts of
2 or 3 patties and
fat and bacon and whatever else you can decide.
Yes, it's delicious, but he disagrees with that, I guess. If he wins, I have to eat vegan for a week. And he said he'd help plan the meals, which actually really kind of ticked my wife off when she heard that. So
now I saw you training, though. You had like a sweatband that said Beat Bergman or something.
I wrote his name on there, got dialed in. We made it happen, 1924. Then we went to Zombie Burger, and the poor guy walking back to his car at the end, you've never seen someone so disappointed in themselves.
I was there for both of those events. I'm acting like I don't know what's going on. But
you were running right behind me saying, go faster.
I was running right behind you, but on another treadmill. But I think he was probably sweating more eating the burger than you were running the 5K.
No, we had it all the way. You helped me train for it.
Well, that's the kind of competitive guy I'm talking to here. He's a big athlete and really busy, excellent sports doctor. And today we're going to talk about ACL reconstructions. There's so much to talk about here. I hope we can get it all done. Some of the stuff will be interesting for just beginners, lay people. Some of it might be something that medical students or such might be interested in. I'll just say an ACL is like the main central ligament in the knee, controls somewhat the shin bone moving forward on the femur bone. It controls some rotation too. It's really an important ligament in the knee. Can you tell me how people might tear their ACL? It's the anterior cruciate ligament.
Yeah, absolutely. There's primarily two mechanisms. There's non-contact, where they come down from a rebound or they make a cut and their knee gives way. Or there's contact injuries where football, you see a helmet violently hitting a knee and the knee kind of going sideways, and then they're laying on the ground in pain. A large majority of them are non-contact, actually, and the patient can't even believe it. They say, no one hit me, I just came down, and all of a sudden I couldn't walk and my knee swelled up.
Do some people feel some kind of a pop or anything like that, or usually not?
Most often they go down and they know something happened. Sometimes they hear a pop or feel a pop. Sometimes they just feel like their knee gave way, and next thing they know, it's swollen and they can't really bear weight for a few days.
It's a pretty common injury. We hear about it in the pros too. I remember Adrian Peterson, had a tear. He got back phenomenal shape in 6 months, which is not the norm. I don't want people to think that's the norm.
Right.
But, some people might be interested that Klay Thompson tore his ACL last year for Golden State. And then can you tell me about that? How he's able to still function a little bit? Yeah,
it was kind of interesting. He got back up. I believe he knocked down 2 free throws after that. When you're standing, you have enough support. You don't need the ACL to stand and shoot a free throw. He was courageous enough to do that. I think he even backpedaled afterwards to get back on defense, but he probably wouldn't have been too valuable. Eventually after an ACL tear, you can bear full weight. You can function rather normally. It just comes to that side-to-side ability or that explosive ability.
So for sports, you need to maybe have that addressed, but for walking in a straight line or climbing stairs, usually you don't have to.
Yeah, absolutely.
But most of the time, if you want to get back to sports, you need to take a look at that. Can you tell me, there's some interesting patterns, like who gets an ACL tear? Like who is a high risk for this?
Females are about 4 to 5 to 1 compared to males. And that's for a lot of reasons. We think there's kind of a lot of things to do with how they land and the angles at which their knees perform actions like cutting, pivoting, and shifting. And so that's why and you see it in your practice too. You see a lot more females coming in.
Yes.
Than males. There's also more high-risk sports than others. You have soccer, basketball, things like that, football.
This is probably a whole topic on our podcast, but you think the exposure to the sport, how one sport athletes are doing the sport all year long, they might do soccer for 10 months instead of 2 months like when we were in school. You think that has anything to do with it?
Yeah, I think without a doubt we've identified that no matter what the injury pattern, what the sport, I think recommendation, at least that I give in clinic, is that every kid should take at least 3 months off from any sport they're playing, simply because the adaptive changes that happen to the body, over time, leave you prone, susceptible to these kind of injuries that can happen. So cross training is fantastic in terms of, I want my kids growing up to play multiple sports for that reason.
All the Hawkeye football coaches, everybody's all about 4-sport athletes, and people who do a lot of different things well. I think probably in part because it might limit their risk for injury.
Absolutely.
So we talked about how you can walk a little bit, you could jog, you could bicycle without an ACL, and probably not do further damage. But who really needs an ACL fix or reconstruction? In particular, of course, we think of athletes, and I think that's a no-brainer that if you want to do cutting and pivoting, you need to have your ACL in good shape. What about, extremes of age, like maybe a 55-year-old person is one extreme, and then the other one would be somebody like how about a 13-year-old boy who maybe looks more like a 10-year-old boy? They're not quite through puberty yet, that sort of thing. How do you address those two situations? Yeah,
let me start with the 13-year-old kid. So skeletal maturity is kind of how we rate people based upon how they're growing. We know boys tend to grow till they're about 16. And so we can look at radiographs and kind of determine what the growth plate looks like, how much longitudinal growth they have left. The reason you bring that up, I think, is it's important. If you do the reconstruction, you have to be cognizant of the growth plates. You don't want to cause them to have an angular deformity of any variety or anything like that. So I think about 10, 15 years ago, a 13-year-old, maybe even younger, people thought, okay, let's brace these kids. Mm-hmm. Let's get them a little older, a little bigger, and then do the ACL reconstruction. I think lately there's been a change in that development. And with the advent of some pediatric sports medicine specialists, we now kind of know that there are different techniques that can be done to spare the growth plate or minimize any damage to the growth plate. And the reason we think that doing an ACL reconstruction for a kid makes sense is that you're really trying to prevent injury to the other structures in the knee.
Right, like the meniscus,
cartilage, mm-hmm. Exactly. If you let a kid go play, he's probably not going to tell mom and dad my knee gives out on me every so often, but he may be doing irreversible damage, because you can reconstruct an ACL, but it gets really tough when you start losing your meniscus volume, your cartilage, mm-hmm. because then you're really set up for problems down the line.
Right.
In that 55-year-old you're saying,
right.
In my practice, most 55-year-olds that come in with an ACL tear, it typically happen because they're fairly functional. Mm-hmm. And so they tell me, I ask them kind of, what are your goals here? And if their goals are to do anything active where they're going to feel some kind of instability, I do mm-hmm. offer them reconstruction. Mm-hmm. There are a few that decide, I think I'm going to go without. But majority of them tend to kind of say, yeah, let's do this. I'd like to get back to the level I'm at. And as you know, 55 is a new, 40, honestly. I mean,
not quite 55.
Yeah.
Thank you. So, and if they do decide to do non-operative treatment, we focus on hamstring strengthening, right? Mm-hmm. Plus or minus maybe a brace, but which maybe hasn't been shown to eliminate instability episodes, but might give people more confidence to get back to playing.
It's probably, more or less, it probably just reminds them they have an issue going on, and to take it easy or something.
Right. Well, there's, those are kind of the generalities of, who tears ACLs and how we address them. So let's say you have an ACL tear, your surgeon does an exam. We can usually tell just by feeling if there's mm-hmm. ACL tear. We often get an MRI, not necessarily to check the ACL, but also to look for associated injuries like you're talking about, which can be the worst part of it.
Yeah.
A big meniscus.
Do you always get an MRI in yours?
I do. I've had a little pushback sometimes from insurance on that, like if I'm sure they have an ACL tear, but I always get an MRI.
Yeah, I'm with you. I feel like with advanced imaging now, it's harder these days to have guesswork ahead of time. I think patients really want to know exactly what you're going to address. If they wake up with a meniscus repair and they can't bear weight afterwards,
right,
they're kind of upset with you. Why don't you tell me that ahead of time?
It's just best for the discussion ahead of time, so you can tell people you could tell people you've got a piece of cartilage that's floating around in the knee mm-hmm. that we have to address, and also you can have the equipment ready. Although we have all the equipment at the surgery center already, it's nice to have all that ready to go. You know how long the case is going to take. It's not 45 minutes. It's now an hour and 45 minutes.
Absolutely.
That sort of thing, and you can counsel the patients. So what I love talking about, too, is, for some things, there's one answer for everything. For mm-hmm. ACLs, there's a lot of different answers for how people do it. There's variation from coast to coast. There's variation from where you trained on what graft you use, how you do it, etc.
Yeah.
So that's what I want to talk about a little bit too while we have some time left. So initially, I know they did a lot of weird stuff back before we were doctors, mm-hmm. Trying to sew it together or putting some Dacron mesh in there or something like that. Why can you or can't you just fix an ACL?
Yeah.
Tore, why don't you fix it?
No, that's a good question. And a lot of people come in saying, "Oh, you're going to repair my ACL," right? They say that a lot, and you have to kind of correct them because you don't want them thinking, "Yeah, I'm going to put some stitches through this." If anyone actually, once you scope a knee, you kind of understand why it's not really repairable in most circumstances. Because, first of all, a lot of times it's a mid-substance tear or near the femoral insertion, and the ligament itself is folded in front of you, and it looks like a blind stump after about 2 or 3 weeks. And the ability to put anything through that of any value, and so, right away it needs to be reconstructed. Right. There are very few where maybe there's a partial tear of one of the bundles that mm-hmm. could you potentially tighten that back up, maybe. But I think that the force that goes to the knee when you injure the ACL is strong enough that even if the ligament looks okay, on the inside, it's altered to some degree,
so basically, if it's functionally unstable, you need to reconstruct it, not repair it.
Correct.
And then the next question that people ask about, and not everybody does, but is graft choice.
Yeah.
And there's a lot of controversy about that. The graft is what we're going to make the new ACL with. Your choices initially are from a cadaver or from a from the patient's own body. So are there some people that you would never do a cadaver graft in, and some people that you would most likely do a cadaver graft in?
Yeah, good question. I actually, a few times I've had some patients almost decide to leave because I've told them if they're young enough, and I think anyone in their 20s or younger personally, even in their 30s, I tell them to use your own tissue. That's what we call autograft. Because some people come in and say, I like an allograft. And I actually saw that on the West Coast sometimes. A lot of MMA fighters would come in and say, I got a fight coming up. I need to be trained in. Let's do allograft so there's no morbidity, and I'll fight. And if I tear it again,
meaning pain from the harvest site.
Yeah, so they don't want pain from where you're going to take the graft from, or maybe the loss of function that may be subtle, but they think is a big deal to them. But I think teenagers, college athletes, even into your 30s and 40s, I really recommend using your own tissue. Because I think that we've learned that the failure rate is much, much less than using allograft tissue.
Yeah, absolutely. So for college athletes, high school athletes, they need to use their own tissue in your practice and in mine. Maybe in somebody my age, if they want to not have the morbidity from harvesting.
Yeah, you could have allograft all day long.
Low-functioning athletes could have what I take, which is probably an allograft, so I can get back to work in a week or something.
You could, yeah.
Then, I mean, this isn't as important because everybody's got their own opinion, but what about hamstring and bone, tendon, bone?
Yeah.
I know there's been research that shows that both are equivalent. What do you think about that?
My practice is probably about 60-40, or maybe even closer to 50-50 now.
Which way? 50-50. Which way?
Yeah, tricky question.
Yes, I know.
I would say so. I'd say 60% bone, patellar tendon, bone. 40% hamstring. And that may be just the bias of the practice that I'm in. I still think for high schoolers and college athletes involved in any cutting sports, I like bone, patellar tendon, bone. There's a lot of advantages, and what we mean by that is you're taking a plug off the patella, the kneecap, and then you're taking part of the slip of the patellar tendon and then part of the tibial tubercle. So there's two bones on the end of a tendon in the middle. And so what you do is you replug that into your sockets, and you can compress that, or you can suspend it with fixation. And ultimately, I think the healing is a little bit quicker in studies, maybe a couple weeks in terms of integration.
Especially if the patient's kind of a squirrely high school kid, and you don't know if they'll wear their braces or anything like that.
Exactly.
So for some people, you use hamstring, but for your go-to is BTB, bone, tendon, bone, patellar tendon in athletes of the college, high school age, most of the time.
It is. I think my bias is formulated just from my fellowship training out on the West Coast, and I saw that routinely utilized.
It's very regional, isn't it?
It is regional, and in residency in Chicago, I probably did a little more hamstring, which is a fantastic procedure as well. When I was
at Mayo, I'm sorry to interrupt. When I was at Mayo, all we did was BTB, and then I got bone, tendon, bone. I got here, and all the sports guys only did hamstring, so it's very regional.
I was told when I moved here by someone in the medical world, not a doc. He said, "What do you use for ACL?" I said, "Well, I use either." But he said, if you don't do hamstring, you're not going to get any ACLs in Des Moines. He said, that's how biased the town is. And so I don't fight with anyone. If they're convinced they need hamstring, that's totally fine, totally acceptable. And there's occasion I'll do an all-inside graft as well, which is a nice technique. I think you need to know how to do things a bunch of different ways to treat your patients.
I agree, And the nice thing about a bone, tendon, bone is it's going to be a certain size every time. A hamstring, you might be in a smaller, like we said, a lot of these are women. Might be a 14, 15-year-old woman, and you get a hamstring that's very small and wimpy, and those might have a higher failure rate. So you're predictable if you use a bone, tendon, bone.
A little bit more,
You can get some anterior knee pain or front of the knee pain if you don't rehab correctly afterwards.
You can. I think with newer techniques, the way that if you protect the sheath that surrounds the tendon, and I think if you bone graft in the patella, and this is anecdotal, but in my experience, the complaints of anterior knee pain seem to be less than the
That's great.
prescribed 10 to 30% that they claim can happen.
So, but typically, if we look at the research, whatever graft, if it's done correctly, has good success rates for ACL reconstruction. Just
Correct.
kind of go with however the surgeon was trained and what they think, but feel free to ask questions.
Yep.
A couple other little controversial things that we can clear up, hopefully, before we move on to some post-op protocol. I think we have just a few minutes left, but one thing would be that a couple of our partners, Dr. Honkamp and Schulte, trained with Freddie Fu, and he was a big proponent of the double bundle because there are two distinct bundles to the ACL, which have a little different function. What do you think about double bundle technique? What is the research showing about doing 2 different tunnels, 2 different grafts to make the ACL more anatomic?
We've learned so much from Dr. Fu's research, and we understand there are 2 bundles to the ACL. I think that in maybe some revision settings or recurrent instability settings that you might consider going that route. I think the national trend among most of the sports docs that I'm aware of is still to do a single bundle reconstruction and kind of err in between the 2 bundles as your isometric point for your graft. Because longitudinally, if you look at performance, it's pretty much the same in most studies that I've seen.
Yeah, exactly. Okay. We could talk about tunnel position. There's a couple different ways to drill it. But I think I'd like to talk a little bit more about, I think that's, kind of surgeon dependent, but I'd like to talk a little more about what's it like after an ACL reconstruction.
Yeah.
What do you do in the first month? What's your return to sport protocol, et cetera?
Yeah, so everyone's a little bit different, but I have them locked out straight until they see me back in the office, usually 7 or 8 days later. I do get them set up.
You mean
actually
in a brace? You put it out straight?
In a brace, straight in a brace.
Surgery takes about
an hour.
Okay.
Let's say, depending upon graft or complexity, if there's a meniscus tear or whatever there may be. Majority of my ACLs get a continuous passive motion machine.
Okay. A bending machine?
Yeah, I like that just because I think it gets them moving a little bit. So they come out of their brace and they do that a couple times a day. So that helps them work on some early range of motion. And it also lets us not worry about PT right off the bat. When they come see me, I take the dressing down. We address their wounds and everything. By that point, things are starting to calm down, and we get them into physical therapy. And the physical therapy, we have a protocol that, myself, the sports guys have kind of all streamlined here at DMOS. And ultimately, it takes them through working on their extension, working on some co-contractions, the quad and the hamstrings, working on just getting the swelling and the edema out of the leg, putting full weight down.
Put weight on it the first month.
I let them put full weight down right away. And ultimately, when they can perform a straight leg raise, I feel comfortable unlocking the brace, letting them walk and getting off crutches.
Maybe a month to 6 weeks with brace?
Yeah.
Or whatever. It depends on how quick they wake up the muscles, right?
Exactly. And some people get some quadriceps atrophy. That means the muscle that extends your knee kind of goes to sleep a little bit. Sometimes they take a little bit longer to come back and need the brace for a little bit longer.
So I know everybody's different, but now my 2 other questions for you are, when would you let them go back to sport if everything is functioning really well, and if they have their own tissue, not with a cadaver tissue? And then also, my last question would be, do you think that a ACL functional brace is helpful, or is it, again, just a mental kind of thing to give confidence?
So most docs across the country, I think, are about a 6 month. For me, it's 6 months where I feel like, okay, if we've hit all our parameters we need to hit, you can go back and play sports. I think we all realize internally that may be a little too soon for some people because when you test their strength side to side, it can be a lot weaker than you think. Yeah. And so I tell everyone that we have some newer ideas on like people's own anxiety and confidence levels. That's actually as important as their physical progression. And so I tell everyone if they feel confident, they want to get back. And we have some newer things at DMOS where we can test their strength side to side. And if that all matches up, 6 months is fine. Anything before that, I tend to tell them not to do. There's plenty of, I think, patients of mine who probably do their own thing and maybe get by with it. Yeah. But studies will tell you that the graft continues to mature until almost about 2 years out. You're basically taking a tendon and you're making it, the body has to make it become a ligament. That takes a really long time. Right. And it doesn't happen all by 6 months, but usually they're strong enough to get back around that time.
Well, it's one of the most fun procedures to do, getting patients back to sports that they love. Ideally, we would address this ahead of time, and people are doing that with, especially in high-risk groups like women in soccer, and working on strengthening so that we talked about some of the defects that some athletes have with weakness in the hips and in the knees. So ideally, we'd have this never happen and not have to do surgery, but we do have good techniques to fix it. I really appreciate you coming on the podcast and telling us all your expertise about ACL reconstruction. And I think this is going to be a great podcast for us.
Thanks for having me. It's good times.